Right, good morning everybody and welcome to this meeting of the NHS Devon Board. My name's Sarah Wollaston and I'm the Chair of NHS Devon. I'm particularly delighted to be joined today by June Symes and her husband Bruce, who are going to be sharing their story with us. Thank you very much for joining us. And also great to welcome Richard Ibbotson, the Chair of Torbay and South Devon Foundation Trust, and James Brent, who's the Chair of University Hospitals Plymouth Trust. So thank you very much. And thank you too to Susan Masters, who's joining us because Deputy Chief Nursing Officer, because Darren Alcorn has now started his secondment to University Hospitals Plymouth. We also have a number of external observers in the room with us. We have Jonah Broad. Thank you very much, Jonas, who is joining us from NHS England as part of a course, and is going to be an external observer for us today and to give the board feedback on how we're performing. And we're also joined online by Mark Cook and Martin Smith from NHS England as observers. So thank you very much to everybody, and welcome to all members of the public who are joining us both in the room and outside. So just wanted to note some apologies, if I may. We've had apologies from Kate Shields and also from Sandy O'Hara. And I just want to confirm with Jodie that the meeting is quorate. Thank you very much. So I want to also just make a couple of announcements, and one is that at the private meeting of the board in March, the digital strategy was approved and it's now publicly available on our website. And the terms of reference for a joint working agreement with NHS England for specialist services was also approved, and that's going to be included in our governance handbook, which is also available on our website. And I just want to note that following this board today, there'll be a private board meeting. And just to make it clear what we'll be discussing at that, we'll be having a further discussion of our workforce strategy, our board development and organisational change, and updates on those items will of course be shared in public in the near future. So could I just ask, are there any amendments to the declarations of interest published that anyone would like to note, or any things that are especially relevant to items on the board today? Thank you. And then could I come to the meetings of the meeting that was held on the 15th of March? Does anyone want to raise any points about those notes? Thank you. So we come to a very important part of our board meeting, which is our citizens' voice. And as I said, very, very welcome to June Symes. We're very grateful to you for coming to share your experience. And what we're going to try for the first time today is holding this as a more of a structured interview, so that we can make sure that all the points are across. But if there's anything that you feel that we're missing out that's really important for us to hear, please do say. So thank you very much, June, and thank you, Sam Cush, from our communications team. So I'll hand over to you.
Thank you very much, Sarah. So yeah, as Sarah said, we're doing it slightly differently this time. So we're doing it as a bit of a structured, kind of informal chat with June. So thank you, June, for being with us today. So we're here to talk about June's knee replacement and some of the issues that you had with that, and particularly waiting and the impact that pain had on you.
Yes.
So I wonder, just for everybody's benefit, could you just give us an outline of when you first started to get knee pain and what advice you sought?
Well, I'd had knee pain for a long, long time, and I did have injections with the doctor, but it became apparent that I needed a new knee. So I started down the road, as you would, with the NHS. I'm a great believer in the NHS, I have to say, generally. And I just got referred to physiotherapists, all saying you need a new knee, but it didn't culminate in me getting an X-ray. And months were going on. And the last time I saw a physiotherapist, he did write a letter, and whom it may concern, what have I. And I thought, well, I can't stand this pain anymore. I've had it months. Unfortunately, it was combined with the fact that last year I fell and fractured my spine. So, and the treatment for that didn't work. So I not only got my back, I had my knee. And so I got to the stage and I was extremely depressed. It has an effect on you. It affected my life. My husband's very active. And I couldn't garden, I couldn't walk. We had a dog which we had to get rid of, which was very sad. I mean, my son had him, that's fine. But the whole of my life was affected because there was nothing that I could do that would really cheer me up. You know, I just got into a sort of slough of despond, if you want, and it was awful. So I was getting nowhere. So I did ring Mount Stewart. I had this letter, and I saw made an appointment, had the X-ray within a couple of days. Saw the consultant, had a look at the X-ray, which was pretty horrendous. There was absolutely no cartilage there whatsoever. You know, it was just awful. And so I said, well, when can you do the operation? And he said, it was getting towards the end of the month. He said, next month. And he said, and I said, well, how long to wait if I do wait on the NHS? And he said, about 18 months. And I just couldn't bear that. So I was fortunate to be in the position to be able to afford the operation. But at the same time, I wished I'd have been able to have gone through the system, you know, because I believe in the system. But it is broken at the moment. I know I'm speaking for loads and loads of people. And now I'm waiting another 6 months to have an epidural, you know, a lumbar epidural, which seems interminable because I still can't get about. The knee's a success.
Could I just say that trying to get the initial X-ray with the National Health, it became a farce, going from one to the other and saying, oh, you've got to get a senior physiotherapist. Everybody said, yes, you definitely need a new knee, they've only got to move it, they could hear it crunch. And I said, well, we'd better go to A&E and say you've fallen over, perhaps you get an X-ray that way. But then I phoned up Mount Stewart and I said, when can you do an X-ray? They said, oh, come in tomorrow.
Yeah, and I took the letter that the original physio...
Actually, it was when we came to book it, it was about a week, but that's how it all started, really. But it was just a joke trying to get the X-ray in the first place.
Just being passed from one physiotherapist to another, then the consensus was, yes, you need a new knee, and that was it. And it was just trying to get an X-ray. I mean, if I hadn't have had this done privately, I'd still be waiting for an X-ray. Simple as that. You know, I've not heard anything at all. So.
Can I just ask you? So you talked about, I think you saw 3 physiotherapists,
yes.
didn't you? And each time, obviously, there's a wait between each of those.
Of course,
and
yes.
What impact does that have on your your mental well-being?
Well, it's extremely depressing because you can't see a light at the end of the tunnel. You know, you think, well, when is it going to happen? What's going to happen? And I couldn't do anything. This was the thing, because I am active. You know, I do belong to different organisations and...
I mean, if I could just say, my wife's... I hated to see her crying in pain. We got a dog, but we had to let the dog go because I couldn't look after them both.
No, for someone that's nearly 90 years of age, does the park run, you know, he's pretty fit, but it was not just the mental effect on me, it was on my husband as well. And we were desperately sad to lose the dog, but, you know, you have to be practical about these things. He went to my son, that's fine, we can see him, but it was as if really our whole life was collapsing, because I just couldn't do anything, couldn't make any contribution, couldn't couldn't cook. My husband has been a real stalwart looking after me. And when you lie in bed at night and you can't sleep because the pain is so intense. But although I have been depressed, very depressed, I've never had suicidal thoughts. My glass has always been half full, hopefully. But it did get quite bad, really bad, particularly over Christmas. And I mean, I know we've had COVID and all that, but holidays have been out of the question, and we've got families scattered all over the country, and we've not been able to go and see them at all, because we can't drive. Well, we can drive normally, but we haven't been able to. And so the alternative is the train, which you think about, and you think, oh, is it worth it? So consequently, we haven't really seen much of our family, so it's had a profound effect on our life altogether. It really has. I'm feeling much more positive now, obviously. And if I can get my back sorted out, that'll be fine. But no, it was the fact that I was just being passed from one to the other, one to the other, one to the other, and not getting anywhere. And you feel your life's not valued. You feel worthless, really. And this is happening with so many people. And I feel desperately sorry, because not everyone is in the fortunate position to be able to afford to pay for an operation.
Can I just ask, June, thank you for sharing that. So we talked about the physiotherapists that you've seen.
Yeah.
Were you offered any advice in between seeing those physiotherapists?
No.
And would that have been something that would have helped, or is there anything that...
Well, it would have helped. I mean, they say, well, try and do this exercise or that exercise, and just to keep yourself going, really, so you don't lose your muscle strength, because that goes completely if you can't walk. Mm-hmm. But there was nothing specific at all. No advice. No advice. So it was just sort of get on with it, really. I can't explain it. It was just... Well, it wasn't indifference, because they're all very nice when you see them, but they're doing a job.
Do you mind if I ask just a point of clarification? Did you go back and see your GP and ask for a referral to see a specialist, or were you seeing the physiotherapist in the hospital's clinic?
Yes, I was seeing the physio in the hospital clinic.
So it was within the hospital clinic?
Oh, yes.
And did they ever discuss with you putting you directly on the waiting list, or you being seen by one of the specialists within the orthopaedic team within the hospital?
The physio, as I say, gave me a letter recommending that I have this and going to the doctor, but by that point I had just got beyond going to the doctor, so I took this letter. This letter went to Mount Stewart, and of course he'd put all the specifics in.
But just to clarify, were you ever actually added to the formal NHS waiting list for surgery, as far as you know? So it was actually getting on to that was the delay. I just wanted to clarify that.
Because I never had an X-ray.
Oh, right.
Okay. They can't do anything till you've had the X-ray to show
you.
exactly what's going on. And I never got that far. No.
Well, thank you very much for sharing your story, and I know there'll be a lot of interest, and this does link in with our discussions later in the board today. I can see that Nigel would like to come in, Nigel Aitchison, who's our Chief Medical Officer.
Hello. First, thank you both for sharing First of all, thank you for sharing your story of how not only the way it impacted on you, but on the broader family. And I think that the first thing to say is that what we're trying to do as a system working together is to try and have those what matters to me conversations so that we can support individuals to build their resilience, to manage the things they want to do that are important to them and in communities. And that's really one of the key things that we're trying to do to improve the health of the people of Devon, not just the health care, but turning now to the health care. The situation that you unfortunately find yourself in, as you will be aware, is not unique, unfortunately, at the moment, and there are a number of reasons why that's so. But in particular, Anthony and his team are doing some fantastic work with colleagues, and we've got chairs of some of our organisations. We've got one of our chief executives of the trust working very, very hard to try and recover that position, try and reduce the waits for people, both for outpatient and then inpatient waits. And in fact, some of the work that's being done in Devon is absolutely pioneering. You may well have heard about some of it at the Nightingale Hospital in Exeter. Now, that's a small part of what we're trying to do to regain the grip on those waiting lists. But thank you for sharing that story. You know, certainly it really gives some motivation to colleagues who are working very, very hard in our provider organisations to try and make sure that the situation you find yourself in isn't one that persists for long. So thank you.
Yeah. Well, I know I'm not unique. And of course, we have an ageing population, and it gets worse.
Thank you. And Liz Davenport would like to ask a question, who's the Chief Executive of Torbay and South Devon Foundation Trust.
Thank you, Simon. So my name's Liz. I'm Chief Exec in Torbay, just down the road. So I want to start off by offering an apology, because your experience of that pathway is not the experience that you should have had in terms of that pathway. And speaking to what Nigel says, we know that a number of people wait, and we are later on in this meeting are going to look at our performance information, and it's going to tell us about the number of people that are waiting for operations. I think what's really powerful about your story is every single person on those lists are people whose life, is impacted by their waiting for treatment. And I think it's really important for us as a board to be very aware that some of the decisions that we make have impact on people and their lives. And I know, having been an occupational therapist in a former life, the importance of doing the things that are important to you, to your overall well-being. It does create impetus around some of the innovation I think we are beginning to see across Devon that enables us to see more people more effectively and do more ambulatory care. And all of that is going to be really important in terms of increasing the capacity we have locally so we can see people more rapidly. But I'm sorry your experience was the experience you've had, because it's not what me or the clinicians in my team would have wanted you to have.
Oh, well, thank you for that, yes. I know I'm not alone, but it's personal to me. Yeah.
Thank you. I can see that Hisham Khalil would like to come in. He's joining us online from Darriford. Thank you, Hisham.
Good morning, and thank you very much for sharing your story, which is a very powerful one. I guess my question is, how easy did you find it to share your experience, the impact this was having on your whole life, as you really eloquently described it, with other healthcare professionals within NHS Devon? How easy was it to get your voice of what impact this delay in getting your X-ray and going on the waiting list was having on you?
Well, it was my husband that initiated this by writing to the NHS, and that once that had happened, I got a response pretty quickly from Sam. I wasn't quite aware it was going to be like this, but this forum. But I'm just happy to be able to tell people how it impacted on me, because it must be doing the same for hundreds and hundreds of people. But I have to say I'm very pleased to be invited and voice my opinions.
Well, we're very grateful to you for coming. And I see Sarah Lou wanted to come in, and then Judy Hargaden. Thank you.
Yeah, thanks ever so much for sharing, for both of you actually. So I'm the mental health partner on the board, and I just wanted to ask, from a wider impact on your life, what would have helped you through that really difficult time? So whilst you were waiting, we understand that side of things, but from you as a family, what do you think would have been useful to you because obviously it has impacted for both of you.
Yes.
So during that time, is there anything you can think of that you think might have been useful?
It would probably be nice just to have spoken to someone, to talk about it, to offload, really.
Yeah.
we know there wouldn't be any quick fix, but to talk about it, because you can't talk to your friends about it really, because they get bored to tears. You know, they've got their problems as well. So someone that had an understanding of the system, it would probably have been very good.
And for you, was anything ever offered to you to?
Well, it was just the long waits. You know, everybody's lovely and said, yes, you definitely need a new knee. But the doctor initially said, well, I can't refer you myself. You have to go through a physiotherapist, which I thought was daft. I mean, he's a doctor. And he'd been giving her injections for years, and he could feel the bone. He said, yes, you need to. He said, I can't refer you. You have to see a physiotherapist. Then one physiotherapist, they said, oh, yes, you need a new knee. But then you went to another one, and then another one, and then we just weren't getting anywhere.
That really frustrating.
Yes. It is frustrating.
Thank you very much. I'm going to bring Judy Targeton in next.
Thank you very much for sharing your story. My question is not going to be to you, but to the executives who I would ask for some reassurance on a particular issue. My understanding from what you said was you didn't even get onto the waiting list for having your knee replaced. So we weren't getting statistics on how long you're waiting, because once you're on the list, then we know that there is a problem, and we know that. And so for me, this highlights that our pathways, which are intended to speed up getting through the system, may not always be working. I'm not going to ask anyone for an answer today, but I am going to ask that at our next meeting, we consider what's happening in the space between the GP says to the acute service, this patient needs something more, and you finally getting on to that list. And it feels to me like there's some issues about who has permission to do what, and if we're putting in these extra steps, we must make sure they work. So thank you very much. I should add, my husband is just starting on the same route as you, so I listened with extra acute ears, but thank you so much.
Can I just very quickly say on a very positive note, because my husband probably wouldn't say anything, but he had bladder cancer, and the treatment was superb. From the day he was diagnosed to his op, it was 6 weeks. And his follow-up and his infusions and everything were just wonderful. They've stopped now because there's a shortage of BCG. But as he's absolutely tip-top. But that is a very positive thing. And we were delighted with the way he was treated.
Thank you. And we have a final question from Anthony Fitzgerald, who's our Chief Delivery Officer.
Not so much a question, but firstly, thank you very much for highlighting a couple of issues there. And in response to what you've said, but also to the point that Judy has raised, I think there is something we need to do in terms of looking at the pre-waiting list cohort of patients. We're very much focused on a waiting list, but actually you've highlighted a particular issue that we will be looking at, and I think associated within that is around the communication, the bit about pathway navigation. We expect people to know what pathways are going to be without sometimes telling them what the pathways are going to be. So there's two actions from me, from what you've said. One is around the cohort of people who are waiting to get on the waiting list and to give some assurance to the board around that. But also I think around that communication piece, which is still sadly neglected, I think, in many areas. So we'll be looking at that as well.
For what reason? Because it wasn't always the case. Can you not have the direct referral from the doctor now? People have to go and self-refer. Was that supposed to speed up the process, or what?
I think it was intended to actually stop a number of referrals going through that actually weren't appropriate, because there used to be a lot of non-appropriate referrals, and it may well be that actually our gateways aren't quite right in terms of that, but actually people being in an endless loop, if you like, prior to getting onto a waiting list is not the intended consequence. So again, we would need to look at that, and we'll undertake that piece of work.
Thank you.
Thank you. So, Anthony, could we ask you on behalf of the board to take this forward, to actually look at what went wrong within this pathway, because being seen by the specialist physio within a hospital setting should allow you to then be going directly onto the waiting list where they've made a judgment that is clinically appropriate. So I'm still not clear why that didn't happen. And so I think it would be helpful if you could follow that up with June.
He was a senior physio.
Yes. So I think we do need to. I think you've raised many issues today around not only waiting times and the terrible experience that you had living with the pain you described, the impact that had on the whole family's well-being, yes. And you know the kind of things that happen when people aren't able to exercise. Their general health deteriorates as well. So it does have huge harm for people waiting long times for this essential surgery. So we need to look at that, but also you've raised some very particular issues around the pathway, and so we'll look into that and follow that up. So I'd just like to say on behalf of all of us how sorry we all are that you had this experience that shouldn't have happened, and how very grateful we are to you for coming to help us to focus on the real impact that this has on people's lives as we go forward with the rest of our discussions today. So thank you.
I'm more than happy.
Thank you.
Come along.
Thank you.
It's been very helpful. Now, I know you've mentioned to me before the meeting today that you have another engagement, but you're very welcome to stay for the whole of this, or if you want to listen to the discussions that we've had that are to which your experience is very relevant, all of this will be available online if you needed to do that at a later stage. So at any point when you need to slip away, please do. And again, thank you so much for to both of you for sharing your experience. So thank you.
I have to say, he's been my rock.
That's lovely. Thank you.
Thank you very much for listening to me.
And wish you well with your future treatment. Thank you.
Been some help.
We understand. Thank you very much for joining us for when you have. So we're now going to come on to the next stage of our meeting, and that is just to note my chair's report. I'm not intending, unless anybody has any points that they would like to raise from my chair's report, I will take that as noted. And come on to Jane Milligan's report, our Chief Executive. Is there anything you wanted to draw out from yours?
Well, just a couple of things, really. And actually, I'll also just pick up a couple of points that's in Kate Shield's update from Cornwall and the Isles of Scilly, because, in fact, she's picked up a few things that I forgot to add to mine. So I suppose the first thing to say, obviously, this weekend we had the double whammy of bank holidays and industrial action, and just to reassure the board and other colleagues that a really amazing amount of planning went into place, which certainly safeguarded services going forward. But obviously we recognise that even with the announcement yesterday about the pay awards, we're likely to continue to have some further industrial action going forwards. But each time we do, we continue to work together and plan appropriately. And just to say thank you to colleagues from our provider and also primary care, who all, essentially, have worked incredibly hard to ensure we safeguard services. The other thing, the thing I just flagged was in relation to the meeting that took place a week ago on Monday with our NHS national colleagues. And just, I think Anthony will pick this up later. As a result of that, we have a further submission of our operating plan in some key areas tomorrow, which relate to our A&E performance targets and some of our elective care targets as well. But I'll leave Anthony just to update you on that. The thing just from, just again, to flag from Kate's report, is the work that we have been doing collectively and under Nigel's leadership with the Southwest AHSN and the Peninsula research and development strategy. So we will be bringing that back. Nigel might be able to update us the timelines for that. And then also we have got a relatively new Chief Constable for Cornwall and Devon, who's Will Kerr, he has, as I say, undertaken a couple of round tables, but in fact Sarah and I are meeting him tomorrow as well. And one last thing to say is the 5th of July is the NHS at 75, and some work is taking place with Andrew and others about how we will mark that occasion. I think certainly recognising that, and obviously just highlighted in our citizens' report, we've got considerable challenges, but actually we've also got a lot of services still being delivered and people getting treated, and there's an opportunity almost to be able to, I suppose, celebrate what is going well, but actually also recognise some of that challenge. But certainly we'll keep you updated about what that's going to look like a bit nearer the time. But 5th of July, so that's coming to cinema near you soon.
Thank you very much, Jane. Does anyone have any questions or points they'd like to raise from either of those reports? Liz Davenport, thank you.
Thank you, Jane. I just wanted to pick up on the issue of industrial action and to add to your points. Clearly, there have been a significant amount of work being done to ensure that we minimise the impact, and we have been successful to a degree, but we can't. We have to acknowledge, I think, as a board, that it is having an impact in some of our elective work, seeking to minimise it, but that will come through in terms of how we approach the next quarter. I think the decision yesterday of the Staff Council and what that might mean about relationships between staff and the impact on morale is something also that we need to pay attention to as a system.
Thank you very much, Liz. And Nigel Aitchison.
Yeah, thank you, Jane, for mentioning the research, innovation, improvement piece that we're doing together with ICBs in Cornwall, Isles of Scilly, and also Somerset under the auspices of the HSN. Just to say that the first meeting of what is going to be called the Peninsula Research and Innovation Partnership Board will be, we have agreed that that will be before the end of June 23, and that the sort of coming together of all of the partners, that's all of the ICBs, the Clinical Research Network, the universities and other partners, that will be pulled together hopefully by the end of May. Deadline for the final sort of tweaks to that draft is by the 12th of May.
Thank you very much, Nigel. And then we'd like to hear from James McInnes, Councillor. I beg your pardon, Hisham. I can see you've got your hand up as well, so apologies. I'll come to James next.
Not at all. Thank you, Chair. It's really following on from Jane's report, and I think the event or the marking of the 75 years of the NHS on the 5th of July is also a good opportunity for us to highlight what NHS Devon board is doing in terms of addressing the challenges, given that it's a high-profile date and that the communication in detail to the people of Devon about what we're doing to address the challenges in delivery of healthcare would also be a good thing. Thank you.
Thank you very much, Hisham. So we're now having a report from Councillor James McInnes, who is the chair of the One Devon Integrated Care Partnership. So, James, over to you.
Morning, Sarah. I'm not going to go through the report. You have it before you, but I'm happy for you to answer any. I'm happy to answer any questions I can.
Thank you. I have a question from Judy Hargaden.
Thank you very much. I apologise if I should have seen this somewhere else, but I note that the 300,000 was distributed to the VCSE or through the VCSE sector, and I wondered if there's a list of who that's gone to or whether there is a report somewhere on the allocations.
There certainly will be, and when we have our meeting in June, early June, we will be having a report on where the money went and how successful it was in being distributed and had the desired effect. So there will be a report in which you'll be able to see as well.
Great, thank you.
Thank you very much. So if they could all be noted for the purposes of the minutes, and there are no further questions, we'll move on to our section of this meeting where we discuss improving outcomes in population health and healthcare. And we usually start that with the integrated quality, performance and finance report. But just for those who are following, what we have decided to do is to have a report from the chairs of each of the relevant committees looking, for example, at finance and performance and separately at quality, to that come up within those chairs' reports, areas within this report that have been escalated to the board. But I wonder if anyone has any general comments within the integrated quality and performance report that they would like to raise. Frank O'Kelly.
Thank you, Chair. I think the integrated report is improving and it's good, but it's still, for me, as an ICS, not measuring what we need to measure. This needs to be included, but there's lots of other stuff that also needs to be included. I deliberately didn't say anything when the member of the public came in, because that's my world, trying to get people through the system, and I think it's really important to understand that is repeated every single day, multiple times a day. I deal with it 3 days a week. What is happening is we are creating huge failure demand. So I'm very happy to help Anthony in terms of that processing. And what we need to do is start measuring all those things from the point of the patient trying to, as Judy has said, trying to get access. So how many of the children, young people have their referral rejected? How many don't get into the mental health services? How many don't get through the RSS processes? The issue with the physios probably is just that the physio wasn't able to order an X-ray, so had to refer it back to the GP. It's taken 3 years to try and process so that physios on these pathways dealing with these people in hospital can order the X-ray. So we do need to actually fundamentally look at the processes that are going on for these patients. The things that I think also that we need to add to the IQPR are community metrics. There's still quite a lot missing. And I think one of the other things for me is, if we're all about, one of our 4 aims is about health inequalities, is how many homeless people do we have? How many drug addicts do we have? How many alcoholics do we have? And what are the services for all those people? So, what's there is really, really good, but what we ask to be measured is really important. And I think if we could look at some of those other things, that would really be helpful.
I'm just keen to bring Susan Masters in, because obviously you're leading on this report.
Yeah,
Thank you.
That's fine. Yes, thank you, Frank. Absolutely. Take your point completely about health inequalities and how we look at what our population consists of, what the demographics are. And there is a lot of work going on in that space, in the health inequalities and population health management, and how we bring that and in what process we bring that for sight of the board, and how we build a dashboard to be able to see those numbers, to see what our activity is having an impact. And you're right, that's not there yet in the IQPR, and whether it will be in this report or whether we will have a population health inequalities separate report coming in is still to be determined.
Thank you. A number of people would like to come in. I've got Judy Hargaden first, then Steve Brown from Public Health, and also Simon Tapley would like to come in. So I think, Judy, you were first.
Thank you. I was going to pick this up later under the primary care report, but it's pertinent now to what we measure. We've discussed both at the quality meeting and at the primary care meeting recently that the new measures for primary care are actually having perverse consequences, because the new national measures about who could you see within 24 hours are incentivising a see whoever's available approach, as opposed to particularly for people with multiple long-term conditions, having consistency of care. So in our measures, we need to look out, and I'm sure there are others in other areas, this is one example, for perverse consequences, and have parallel measures that actually keep an eye on those other issues at the same time. So I think it's a generic point, it is a particular issue for primary care.
Thank you very much, and really strong evidence, as I understand, that continuity for people with long-term conditions is very strongly linked to our outcomes and quality. So Steve Brown, Director of Public Health at Devon County Council. Next, thank you.
Thank you, Chair. Just to echo Frank's views, but also pick on Sue's views as well, I think currently working on, I understand it, joint forward plan, an outcome framework, and I think the bit for us as a board is to think about how we're cited on that and how we're doing our assurance around delivery against that, and that might be, as you say, so the totality of that coming, or through the reports from the committees, etc., coming up through. But I think it's really important we're cited on those outcomes as well as some of the output measures which we often see, because that will give us the picture of health and well-being of the population. So I just want to support that point.
Thank you very much. Simon Tapley next, and then Nigel Aitchison.
So in support of what Steve's just said, I was at a meeting about half an hour ago, or whenever we started, about 40 minutes ago, on the joint forward plan, and Simon Chant, who works in Steve's team, was presenting the outcomes framework in a draft. I've asked for a copy of it because it was quite difficult to read, very small, but there's a lot of the detail, Frank, that you've asked for, not all of it. But I think how we get that into this this board is going to be quite important, or I don't know which subcommittee it could go to, population health, maybe, to actually work through, because there are a lot of outcome indicators in there. I think we need to probably fine-tune it, but it will include most of what Frank said.
So could we put it as an action from this meeting that you'll work to update the board and perhaps with Susan as to how we're going to amend this?
And Steve would be helpful. Yeah.
Yes, would be really helpful. Thank you. Nigel Aitchison.
Yeah, just building on that. So Sheena, myself and others, Anne Cooper, as part of her review with Andrew's team of the governance, are looking at a specific subgroup potentially of the board, which would look at population health inequalities and population health management, and then supporting that, working closely with Steve and others, Lincoln's group, trying to pull together what that would look like in terms of the reporting and what that group would look at, and then the feeds obviously into the board. And it's a huge opportunity for us, as outlined in the way we're structuring these board agendas, to have inequalities as a pillar within which we can then start to generate those reports. So all of the comments absolutely in line with our thinking, the development of that approach.
Thank you. That would be great. Can I just ask, Frank, would you mind muting your microphone? Because otherwise I think people online get some feedback from it. Thank you very much. That's great. So are there any other points that people would like to raise from the IQPR? I know that we're going to be having a detailed discussion on some of the points about patient safety within this as well, and in our quality committee report. So I'm going to come on now to Judy Hargaden, who's the committee chair for the Primary Care Commissioning Transition Committee. Thank you.
I've nothing to add to the report, and I've just raised the point I was going to escalate about how we measure primary care.
Thank you very much. So now we're going to come on to a section on tackling inequalities in outcomes, experience and access. We're going to start with an update on urgent elective cancer and diagnostic plans. And that's Anthony Fitzgerald, our Chief Delivery Officer, leading on that, and obviously very relevant considering the very powerful patient story that we have heard.
Thank you very much, Chair. I'm just going to take the paper as read. There are a few things that I wanted to add, though. Firstly, in terms of the presentation that we've had this morning, obviously this paper deals with the known weights, not necessarily some of the unknown weights, and so I will be taking that action to look at that. And although we talk about pathway navigation in terms of emergency care, actually I don't think we talk about it enough in terms of elective care. We presume people know who they're meant to be seeing, when they're meant to be seeing them, and actually what that waiting time will look like. So again, one of the actions I'll take from today is actually to look at that and how we can improve the communication across some of our tortuous pathways, which actually, do take a little bit of navigation and can be made a lot better with some improved communication. In terms of the paper that's in the pack. This tries to detail, or does detail, our approach in terms of elective emergency cancer and diagnostics across this year. And we have reframed our particular delivery boards around emergency and elective care to focus on assurance, but also to drive performance. And I think that's perhaps one of the things that's the difference that we have going forward. We have had our first round of elective and urgent emergency care boards in the last week with very good attendance. And what we're trying to do now is build up the granularity at individual provider and system level across the various aspects of performance. The paper details how we're trying to do that, but also in terms of what we are trying to do with very clear measurement against some quite clear standards. So just to remind people what that would look like, firstly, a reintroduction of a 4-hour standard with an aspirational 76%. We're currently modelling 72% as the minimum that we would want to deliver across our providers, and that's patients coming through an ED department with a decision to admit or discharge within that time. We're also working with our ambulance trust colleagues in terms of category 2 response times to bring those down, and also to stop ambulances waiting in the current number and the current hours lost outside acute providers. That requires a whole system approach. It's not just about what's happening in ED departments, it's about actually how people are navigating systems, what alternatives are there, and as we've mentioned previously, what exists in primary care and other services. We've got a fairly or a very integrated plan. We're making sure that that is not just about spending money, but it's actually about how we're doing things differently. And we're just waiting on confirmation around some particular schemes which do require some funding, but actually that's not the only thing that we're trying to do. In terms of elective care, it's a slightly different story and a slightly different equation. X take away Y equals Z, so therefore it's much easier to model than emergency care, which is multifactorial. And we're focusing on reducing unnecessary waits, and we've heard some examples of those this morning, but actually focusing very much on reducing and eliminating 104-week waits and reducing the number of patients waiting for both above 65 weeks and 78 as well. We're also very keen and very noted that requires investment in pathway redesign in diagnostics. Again, something that was highlighted this morning, but we need to make sure that people are having timely access for diagnostics, not just for elective care pathways, but also for our cancer pathways as well. So I'm pleased we've moved on from having a plan to have a plan to actually getting into real delivery now. And we're starting to see some of those measurements coming through. All providers have committed to trajectories. We do have a resubmission tomorrow, but I think that is a minor resubmission with minor variants of what's been there previously, and we are on course to meet that deadline of tomorrow. Happy to take any questions. There is a lot in this report, and obviously it won't be the first and last time you're seeing it at this particular board, but I'm sure there will be some questions relating to how we're going to be monitoring progress.
Thank you very much. I can see that Sarah Lou Glover would like to come in, and Judy Hargaden.
Anthony, I just wanted to pick up on the idea around pathways and pathway navigation, and I'm wondering if there is something to be learnt from some of the work that's going on in the voluntary sector. And I just wonder if there's something we can almost give to somebody at the beginning of their pathway that says, this is what you can do for self-help, this is what you can do in the community, this is what you can do when things get worse. So you're thinking about that Thrive model that actually makes people aware of what the pathway is and what happens at different levels of the pathway. And I just wonder if that's something that can be considered or is being considered, the thoughts really.
I think it's certainly be considered. I must confess I'm not quite sure about what's available at the moment. It's obviously not enough in certain instances, but we should be using as many forms of communication as appropriate, but also making sure people have links into a service. And I think that's perhaps the thing we need to concentrate on, is points of contact, but also what people can do for themselves as well. So,
yeah, and what's within the community, because these guys clearly, they had no idea that there were Devon carers available. There's they could have had access to them, and what is available for their mental health support for them whilst they're on a waiting list. Because yes, we have a wonderful plan to get rid of waiting lists, but realistically there is still going to be some time where it might be impacting on their mental health. So how do they hear about that whole community that is available for them? So thinking wider than just the clinical diagnostic pathway.
Certainly. And as I said, I will take that forward. I think, we're always going to have waiting lists, and we're always going to have waits. Therefore, we need to invest some time and effort into this.
Thank you. Judy Hargaden.
Thank you very much. And in the sense, I'm going to build on a similar point, but this time from the staff point of view. I raised when we were doing the operational plan discussion how complex all these different schemes must feel to the average member of staff running a ward or a department. And since we have both our trust chairs, all three of our trusts are represented here by 2 chairs and a chief exec, I just wondered what work is going on to make all these different schemes make sense to the average member of staff on the ground, because there are so many initiatives. It just feels very complicated, even when we get it presented quite simply to us.
It's I can respond to that because we had our system recovery working group yesterday, which is the sort of how we knit a lot of this together. And obviously this is one component. There's a huge financial component, there's a workforce component as well. And I think it can be quite complex, and it can seem that actually, where do I fit into the scheme of things? The conversation centred very much on communication to the public, but also to the staff as well. And our comms team are taking that forward with our providers to try and look at, firstly, that we have consistency in information, but also we have the right levels of information available to staff and public. And they are taking that forward for us, because I think it's really important people understand where they sit in the scheme of things, but also that actually what we're aiming towards as well. And that's the bit that we really do need to communicate.
Thank you. I'd like to bring in a couple of our independent non-executive members who are joining us online. And firstly, Sheena Rathana.
Thank you. I think your paper articulates really well the complexity of factors affecting delays in urgent care. And you talk about delayed discharge, you talk but don't really explain unwarranted variations. My question is about the unintended consequences of reintroducing a 4-hour wait for staff within A&E departments, as quite a lot of the causes of delay are actually outside their control. So if you look at sort of some parts of Plymouth where you've got high rates of ambulatory sensitive care admissions, which shouldn't be landing up in A&E to start off with, they might be related to mental health or alcohol, it's very, very strongly associated with the population characteristics. In other places, you're talking about delays in discharge, which might be related to kind of crises in social care provision. So my question really is why are you hypothesising that the reintroduction of the 4-week wait will make a difference? What does that performance target actually change in terms of the complexity of factors that are affecting this? And might it have unintended consequences in terms of undermining staff morale?
I can respond to that. I think we could talk all day about a 4-hour standard and whether that's an accurate barometer of performance. It is a barometer, but not the only. And I think what it does do is give a sort of an indicator of how a system is working. It's never intended to be a ED performance standard. It's always intended to be a system performance standard. And your points around the complexity, absolutely, but it's not to be used ever. And when it was a 98% standard, I was a charge nurse in an ED department. Certainly I was very clear with people, this is a reflection on the whole hospital and the whole system. And the importance of the point that Judy made around communication is really, really important, because what we don't want to be doing is this being a penalty measure for people working in departments. It's an indicator of how a system works and how it comes together. And our plan is deliberately not focused on ED departments. There is a component about actually how you are stewarding and managing within the resources you have. But there is also a recognition that this is far broader, and that's where some of the complexity comes from. But certainly this is not intended to be a stick to beat staff up with in terms of performance. It's actually a barometer of what's happening in the whole system. And the test for us will be how we're communicating that, and then at how we're delivering it.
Thank you. Now I've got Kevin and Hisham waiting to come in, but I know Liz, was this a response to this particular point? Yes, thank you.
Thank you, Simon, my glamorous assistant. So I want to pick up on that. So there's always a lot of debate, isn't there, about targets, but we know that people are in our emergency departments far too long. And if you just look at the data that we report on a day-on-day basis, we have more people waiting beyond 4 hours than should do. And there is an evidence base that says outcomes are impacted by people who are in emergency departments longer than 8 hours, for example. And certainly as an organisation, we're doing some detailed work to better understand what that is telling us, so that we can improve those pathways. So although the target in itself, we could have the debate about, but I do think there are onus on us is to ensure that people are seen, assessed, treated and either discharged or admitted to hospital in a timely way if we're going to improve on those outcomes. I think we need to keep a focus on it. I just also wanted to pick up on a couple of the other points while I've got the opportunity. I think the pathway that we heard being described this morning did not work for that individual, but they were disempowered as a consequence. They didn't feel able to change it, and the only thing they had power over was referring themselves into a private service. We have to check. That's not how our pathways should work. And I think alongside Anthony's offer to look at this, I think there's a provider role here to both understand what happened in this case, but also to look at how those pathways operate, so that we can empower people to take the actions required to enable them to wait well while we're waiting for treatment, because we know people are waiting for access to surgery. I think we also shouldn't ignore the impact on our staff, because our clinical staff who are seeing people wait are finding it really challenging. They want to see those pathways improve, to see people more readily, for us to use our resources in a more intelligent way to see people. And I hear the concept of moral injury being described by my clinical staff over and over again. So we absolutely need to keep a very strong focus on patients, but we should not negate that this is having an impact on our staff, and we have an equal responsibility to them. And to Judy's point around, so how are we communicating this? This is something me and my board have discussed at length, and we are having to prioritise. We're having to focus down the efforts of the organisation into what we call a single improvement plan. But getting out and about into our organisation and ensuring that everybody understands their part in doing it is a critical importance. And we've got what's called a Regain and Renew plan. So that is our banner, and we're getting out and about to every team to make sure people understand the context we're working in, what good will look like at the end of that, but also to support them and helping them take their part in ensuring that we achieve those objectives. And that's a really critical part of making sure that we bring people with us on what is a very challenging journey. Thank you.
Thank you very much. I know a lot of interest people coming in, but can I ask, because I can see Frank, Nigel, Kevin and Hisham all want to come in, do anybody want to respond on this specific point? Because otherwise we'll be jumping backwards and forwards. Yes, thank you.
Sorry, thanks. On the specific point that Liz raises, I think there are a couple of things. The what matters to me conversations are really important, and getting back to the empowerment piece. There is good evidence around pathways where people who are on those pathways are genuinely partners in their care, and there are rights and responsibilities that they have in terms of the preparation for a procedure that can help them recover more quickly and the recovery, but also in the decision making and empowerment. And the other piece then is picking up on some of the people that end up in emergency departments, spending often very long times there, where we know that their needs might be better met in other ways before they come to hospital. And it's one of the conversations that Frank, myself and Steve were having earlier on in that work around, changing how we support people in a community setting is a really important part of how we contribute to improvements in both the emergency department delays and indeed people being in hospital when actually an alternative way of supporting them might be better. So that's again a key part of what we're here to try and deliver.
Thank you very much, Nigel. Can I come to Hisham next? Hisham Khalil.
Thank you, Chair. I just want to follow on the thread about self-care, but with a focus on the waiting well agenda, because this is quite relevant to what we've heard from our Citizens' Voice earlier on. I think there is a need for a focused effort from clinicians within providers and to work collaboratively to make sure that the waiting well agenda is very clear to the people of Devon and that this is communicated in an effective way that they understand as well. And we can see that there are some areas of really excellent practice in that area and areas where this is quite deficient, frankly. So I think there should be a focus on that. The achievement in terms of reducing waiting times is going to take some time. And therefore, I think the waiting well agenda is particularly important here. Thank you.
Thank you very much. I'm going to come to Kevin Orford. Thank you.
Thank you, Chair. And I just want to say thank you to Anthony and team for this paper. I think it's an excellent piece of work, actually. And you know, in some respects, this is about the implementation of the operating plan, which we signed off last month. I applaud the system approach and the pathway approach and the focus on assurance and on granular metrics that runs through the whole document. I think it's a really great piece of work. And you know, and running through this, you know, it reminds us, doesn't it, back to you know, Mrs. Symes earlier in the meeting, that, you know, patient experience. These aren't just targets. This is about patient experience, about outcomes. It's about health inequity as well. So a great piece of work. Just a couple of questions then. At the Finance and Performance Committee, we've signed off on behalf of the board. We signed off the operating plan. This, I think, runs alongside it. We've got a resubmission of minor detail happening tomorrow. And I just wonder if it would be worthwhile to pull together the operating plan, the resubmission and the metrics in here for us to start to have a conversation at the Finance and Performance Committee about how we effectively performance manage this over the next 12 months. That's my question, Anthony.
Certainly, I think in terms of the governance of this, it's making sure that there is the right levels of oversight. And although we've committed to individual trajectories, it's about delivery against those. So yes, we can make sure that all of that's tied together and comes through the right committees. I think also then it's about providing not just the insurance, but actually the description of any mitigations once we start, or if we start deviating from path. So I think just making sure that all of that information is tied together is what we're trying to do at the moment.
Thanks, Ashley. It would be good also to kind of integrate it into the IQPR report, which, you know, going back to Judy's point about so many initiatives, you know, if you added up all the initiatives in the IQPR, but actually this gets us very focused, I think, if we can try and integrate it into that report. But thanks for all your work on it. Great stuff.
Thank you. Jane Milligan.
And thank you, Kevin, and I agree. A lot of progress in terms of how we're describing this, and you have to almost try to, and I think the next step is that triangulation with the IQPR report, because there's a lot in there. Just picking up some of Sheena's comments about the sort of factors. So if we just look at discharges and no criteria to reside, we have some of the best performance in the southwest, let alone the country. But we never talk about that. We talk about everything else, and to some extent we need to be able to describe the whole pathway. The other thing I was just going to say, just in terms of waiting well, and we will probably just need to bring back an update. We have actually previously, I'm pretty sure, commissioned some support to people on the waiting lists, and with particularly that point about how people access through the voluntary sector or through other self-care means. So we just need to go back and double check where we've got to with that. I think it was an initial initiative, but oh, okay, thank you, because I was sitting here thinking, I'm sure we're doing some of this. So yes, so just to reassure you, we are. There you go.
Thank you, but people need to know about it as
Yes.
well. So Frank, you wanted to come back in.
Thank you. It's really picking up on what Liz and Nigel have said. I mean, I think that the really important cultural change is patient as partner in all of this. So we can communicate as much as we like, but I sit in the middle of this complex adaptive system and I can't even keep up with what's going on in terms of pathways and all the rest of it. So we need to be open and honest and have ways of people finding out the information. So what's the waiting list for surgery in X, Y or Z? And if I go to one of the other hospitals, do I get treated quicker? It is a resource. The people coming today were very able to do things, but we disempowered them. So it's a patient's partner and how we empower them to help us sort the problems out.
Thank you. And could I just raise a question about health inequalities within this? Because June is very articulate, but there are, and actually herself said that she was able to afford to go down a private pathway, but there are very large numbers of people who can't, as we heard very powerfully from someone who had to fund their own dental care at our last board meeting. And I just want to ask, because I see within the paper the way that you're prioritising long waiters, the priority 1, then 2, then long waiters, then 3, then 4. But where are we sitting? Can you clarify where health inequalities are going to sit within that? So people who are suffering serious disadvantage already will not find themselves disadvantaged, because we know that's happening at the moment. How we're monitoring that and tackling it.
That's a really good question, and not one I don't think I can actually fully answer here and now. I think I need to go back and look at that, because actually, although we have an aspiration in terms of health inequalities, how that factors in terms of performance is a difficult one to actually articulate here and now. And I think what we need to do is actually just look at that and bring something back.
Because there are tools like the HEART tool, the health inequalities treatment tool, that I think I just would be nice to have that come back to the board to say formally within the next report, how is that being factored in? Sorry, Steve Brown.
Thank you, Chair. Reminded me of I went to the Marmot region meeting a couple of weeks ago, and with Sir Michael Marmot reminding us about inequalities, should we need reminding. But at that event, Somerset Trust gave an example where they've used, through some metrics, exactly this, where they look at the waiting list and those who are most vulnerable, and they did a fairly simplistic scoring system where they were able to elevate up the list to make them urgent to cohort of patients who were the most vulnerable in Somerset. So there are plenty of examples around of tools which can be used.
And this is something that the Quality Committee would be specifically looking at, and we've requested from colleagues who prepare the IQPR to specifically highlight quality data. We have statutory quality data that's there, but we'll be looking into other areas, like, for example, if there's a delay in diagnostics, like in diagnostics for cancer, what impact does this have on outcomes of cancer treatment? So this is an area that we'll be looking at with more focus. And of course, as we heard this morning, the impact on the patient's experience and how we can get assurance that we are truly capturing the patient's experience as well. So that's one area I wanted to highlight. The other area was an area we would like to escalate to the board, really for the board's support in that area, working with our partner providers. And this is in relation to the Never Events peer support group, which has been set up by the system and with contribution from all providers and our head of patient safety. We need some more support in terms of full engagement from all providers across the system, so that this group can be as effective as it can be in reducing or hopefully annihilating never events altogether. So these are the two areas I wanted to highlight, but very happy to take questions about the rest of the report. Thank you.
Thank you. Kevin Orford.
I just want to ask about the escalation point. What precisely is the Quality Committee asking the board to do? It talks about you wanting some action from the board. And the language is a bit loose here, isn't it? It's sort of, you know, less than required engagement, some providers. So can we just be specific about what it is that we need to do? And can I also understand what impact we think full engagement in this would have on the number of Never events that we're experiencing in Devon?
Thank you, Kevin. So the number of Never events is, we are an outlier in Devon with 19 Never events in the last 12 months. That's both the regional and national outlier. So that's the context. The specific ask is that when the Never event peer support group, which has been set up specifically to address this issue and because of previous concerns we've raised, I could say specifically that not all provider representatives have been attending or engaging with that meeting. And I think it's really important at this stage that the board is aware of that and that we have specific support from the board so that all representatives of providers do engage with that. In terms of what this would have in terms of impact, we believe in the Quality Committee it would have a significant impact. And that's something that the head of patient safety highlighted, because there is real sharing of experience about Never events across the system. And as we discussed, there are multiple areas that can affect the reasons for Never events, and sharing this across providers and making sure that if there is an experience in one part of the system, that it is effectively shared with other parts of the system so that such an event is not repeated. So I think that peer review or peer support group is really important in reducing Never events across the system, and it is a tool that other ICSs use. And the reason for the escalation is, as I just highlighted. Thank you.
So I'm just trying to determine the precise board action that we need to take. So this is a governance point. And can I just ask Hisham, as chair of the Quality Committee for the ICB, have you raised this issue with the chairs of the Quality Committee of each of the providers?
Yes, we are going to have a meeting and we'll share with that. This has been a communication with all providers about this, but I think at this stage, you're asking about the tools. It is a governance issue, a communication with all providers about the importance of this group, and that was a specific request from patient safety within the system.
Thank you. It's certainly very concerning to hear there hasn't been engagement. Could I just ask where this sits in with the system clinical risk and harm group that's existing? Is it because some providers feel that they've discussed this within a separate forum? Just be good for us to understand where this sits within the system and whether there's been engagement elsewhere.
I'm unsure whether Nigel is able to answer that as the Chief Medical Officer for the system.
Yeah, Dan and I have arranged a meeting, but we've got an update.
Yes, so that would be really great. Thank you.
Thank you. So this actually has progressed since the last Quality and Performance Committee. There has been a meeting arranged with the providers within the NatSIPS 2 development, so this has now moved forward. A meeting has been arranged. It hasn't yet happened, but it has been agreed, and that piece of work is moving forward. And this is around peer support between our provider trusts, looking at themes and looking at actions and learning from Never events in order to progress and in order to learn from those and to try and prevent them in the future, which is exactly why I think this was raised for the board's sight and attention, so that they could see that this was, Never events has been coming up on the IQPR for some months, and there's been concern around us being an outlier, and the fact that we were struggling to get these communications and this dialogue in the diary was why it was entered onto an escalation to the board. But in fact, that has now progressed, and we have got meetings in plan.
Thank you. Could we add as an action that you update us at a future date through Hisham Khalil's committee? That would be helpful. Thank you very much. Liz, I know, would like to come in, and Judy Hargaden. So Liz Davenport.
Thank you. So in terms of the peer review and the benefits of peer review, absolutely recognise the value of that and would want to support it as an organisation. I think it might have been picked up in part, but I think I'd want to be clear about what the routes of escalation are before they come to a board, because as Chief Exec of one of those provider organisations, if this had not been happening, that I would expect it to be informed and taking appropriate action at organisational level before it comes here.
Thank you. And Judy Hargaden.
I think the conversation and the questions Kevin just raised are important ones for us to look at, not necessarily just for this committee, but for the whole of the way we work with subcommittees. What is the relationship of subcommittees to this whole board? We delegate a lot to subcommittees. What does the term escalation mean? And I'm wondering if we ought to have a sort of escalation for information, but then an escalation for action. And if we actually want action, then maybe as subcommittees, we should be saying what action. So I think this is a very good reflective opportunity about how our subcommittees work with our main committee, because I'm always wondering when I'm chairing primary care, is this something I want the whole board to know? Is this something I want them to do something about? Or is this okay just to send for information? So I think that's been quite a helpful discussion.
Thank you. Can I ask, Hisham, is there anything you'd like to come back to respond to?
Yes, thank you very much. So I think there has been multiple correspondence with providers, and so I still recognise from what colleagues have said, we need to look into the routes for those correspondence and whether the normal routes for correspondence in terms of the peer support group should then be a correspondence from the chair of the committee directly to the chief execs. But there has been multiple correspondence, as we've heard. The difference between information and action, I think it's because of the seriousness of the topic we're talking about. If we're talking about never events, and this has been on the agenda for a number of months, and we have talked about the sharing of information in previous escalations, saying that we would like to encourage the sharing of information. So I think it's a progressive thing. It wasn't the first time that it was mentioned, but I take on board what colleagues have said, and I think the topic of the escalation is also important, and its context in relation to the process we adopt as well. Thank you.
Thank you. And I do feel that given the seriousness of this issue and the fact that it has been within the IQPR for some time now that we've been an outlier, I do think it's reasonable to bring it to the attention of the board, because I think it does help to raise it up the agenda. And so I think I would like to think that all committee chairs would feel they had the discretion for a matter like this to escalate it to the board for information. And as we've heard, there have already been actions taken that will now be updated on. So thank you. Right. Any other points any colleagues would like to make? Because we'll then move on to the next part of our board meeting. But in fact, I do note that we're due to have a break. So yes. So shall we take a break and reconvene? What's the time now? 15:15. So if we reconvene at 11:45, or are we happy with having a 15-minute break? I think that would be enough. So if we reconvene at 11:30. It's unusual to find ourselves ahead of time, so thank you. Well, thank you. Welcome back, everybody. We're now on to the section of our board where we're going to discuss enhancing productivity and value for money. And this is Bill Shields presenting the operating plan and recovery position. We have a verbal update from Bill, so thank you. Bill Shields.
Thank you, Sarah. What I'd like to do is to build on the points that have been made by colleagues earlier in the meeting. So the Chief Executive already alluded to the meeting that we held with the NHS Executive, Regional and National teams, and the Chief Delivery Officer has gone through the issues pertaining to the resubmission that we will be making tomorrow. The Finance Committee had delegated authority last month to sign off the operating plan submission that NHS Devon made. And that followed each of the constituent organisations in Devon having special board meetings where they could sign off their parts of that operating plan. So we met the requirement that is put upon us by regional and national teams to ensure that boards have signed off the plans that we submit. As has been said, the resubmission that we will be making is one that requires some minor changes. We're not anticipating, nor will we be making any changes to the financial position that has been submitted. And to my board members, that is a £49.5 million deficit, and also one that includes a 3-year recovery plan trajectory. We have a detailed report that shows the drivers of the deficit, £242.9 million, which indicates those areas that have contributed to NHS Devon's deficit over the past period. From that, we've been able to undertake an opportunity assessment, and that has led us to be clear about the routes to cash in order to return to a sustainable financial position over that 3-year period. We've also established a system recovery board, and that includes non-executive representation, both from the ICB and from Royal Devon University Hospitals. Each of the chief executives is involved in that, and there is also representation from the Finance and Planning Board, the Urgent and Emergency Care Board, and the Elective Board. Each of those chairs is represented on that board, along with a representative Chief Financial Officer, Chief Operating Officer, Chief People Officer, Chief Nursing Officer, and Chief Medical Officer. So the intention is to have representation across the system such that we are able to lead the recovery programme and report into the region through the SIAG group, which meets every month, chaired by the Regional Director. The resubmission that will be made also includes changes to the elective trajectory. So as has been mentioned earlier, we'll be looking to ensure that we resolve the position related to 65-week waits, and also to be clear that 104-week waits are covered and resolved during the course of the year rather than being left to the final quarter. Our UEC performance will also be changed in the resubmission so that we can confirm the level that we will get to, particularly in terms of the 4-hour wait, and that's something that's been mentioned earlier in this meeting. We won't be expecting organisations to sign off this position at their boards because the changes have been fairly minor, and we've already communicated with each of the organisations how we will do that and how the governance arrangements will work. What's really critical this year is monitoring and delivery of the recovery plan. Within NHS Devon in the past, plans have been produced, plans have been submitted, and then last year being a case in point, have not been delivered against. And that's why the System Recovery Board is really critical. That'll be chaired by myself, and as I've said, there is senior representation at that group so that we're very clear about what is happening, whether plans are off trajectory, and if they are, that remedial action will be taken and done so in a timely fashion. I'm very happy to take any questions, Chair, on any aspect of the operating plan, the resubmission, the recovery plan, or anything else that board members may wish to ask. Thank you.
Thank you very much, Bill, for that verbal update. And Kevin Orford would like to come in.
Thanks, Bill. Just to understand these minor amendments, I'm assuming they relate to the numbers of people waiting at the end of March 2024. And if it is the case that those have changed, we probably do need that to formally come into the Finance Committee and then be reported into the board next time, or is it something less than that that's changed?
So I'll start off with that, and then the Chief Delivery Officer may want to add. When we met with NHS England the week before last, it was very clear from the national team that our elective position would not be accepted. And that was one where we showed over 4,000 patients on both non-admitted and admitted pathways, but predominantly non-admitted pathways, over 65 weeks at the end of the year. We have reforecast that. A lot of work's been done with a number of providers, and also looking to bring in external support to resolve that waiting list position. We do not anticipate that that will make any difference on the financial position. And so in terms of triangulation, Kevin, it's not one that will require us to resubmit. We're very, very clear about the financial position, and that validation and the additional work that needs to be done will be done within the existing financial envelope. And that was the reason for not having a full formal resubmission, as agreed and discussed with the regional tier of NHS England. But I don't know whether Anthony wants to add to that.
Nothing to add, actually. I think it is a minus resubmission, but of course we will circulate that information once it's gone through various approval processes today.
Thank you. Judy Hargaden.
I wonder if I might just talk about how we monitor the operating plan and recovery going forward. Because given that so many of our other plans are on hold while we get ourselves out of SOF 4 and handle the cost improvements that need to be made out of a number of our services, after we approved the operating plan submission at the Finance Committee, I wrote and asked that this issue come to our agenda every time, public or private meetings. And Bill has rightly said he's willing to answer any questions on it, but I have a tab here called Operating Plan and Recovery Position with no documentation. Now, I don't know whether that's a problem with digital, or maybe it's too soon to start reporting on it, and I'm assuming, and Jane is nodding, that it's that. But I would like to ask that we take the recovery plan, which is about productivity, efficiency and delivery of care, as a specific item each time at our meetings, so that we don't end up in December saying, whoopsie daisy, we're not going to make it. And I feel that we as a board, and I know we have a really good finance committee and chair and a really good finance director, but this is about more than money. It's actually about getting our system back in sync. So could we plan to have a regular report on how the operating plan is going, which might be presented by the providers? It doesn't have to be presented by one of the ICB staff, but so that we know that we're not going to get to the end of the year and find that same position.
Thank you. Would you like to respond to that, Anthony or Bill?
I will. So that's a very, very good point. Just to provide some assurance, the System Recovery Board meets every 2 weeks. The Elective Board, the UEC Board and the Finance and Planning Board meet every week. So what we're doing is establishing the rhythm and pace of recovery. And we will, of course, provide regular updates to the Finance Committee and also to the board. But the board will not be meeting frequently enough to allow us to course correct as we need to during the course of the year. That's why we're meeting in the way that we are and meeting with the rhythm and the frequency, which is going to be a particularly arduous issue for all those involved, but it's absolutely necessary for us to do that. So absolutely, totally agree that we will provide those updates. But in terms of the monitoring and the delivery and the execution, that has to happen at very, very regular intervals. Otherwise, it will be too late for us to take those actions, which Judy rightly raises as a concern.
Can I just thank you for that, Bill? And I wasn't at all trying to suggest that the board should be the place where we do the course correction and things like that. But I've spent 4 years trying to get more money into community services and primary care, and I don't want yet again to find that there is no available revenue, in inverted commas, for these initiatives because we didn't keep on top of sorting out the costs in some of our services. So I'm delighted that you're having a very flexible system to course correct, I think was the word you used. But I think this board needs to have regular assurance around that. And that's a bit more than just being told it's been covered in the finance, with no criticism again of the finance committee. This is the major issue for us to get sorted.
Thank you. Could I bring in the Chair of Finance to have a comment on that as well, Kevin?
Yeah, no, I agree with that, and I agree with Bill's response to it. I think the difference this year to last year, I think we're going into this year in a very, very different place, and we've got some very, very specific numbers of maximum people waiting, which I'll refer to in my committee report in a moment. And I don't think we had that focus last year. So I do think that, you know, as we redesign the IQPR for the Finance Committee and for the Quality Committee, that we also redesign it in terms of what's coming into this board, in terms of the trajectories and whether or not we're on trajectory or not, so that early on we can be asking Bill and the System Recovery Board what their interventions are to get us back on track if we're off track. So fully support the intervention, Judy. Thank you.
Thank you. So could we add that as an action, Jodie, that you'll liaise with Kevin and with Bill about bringing these items back to make sure that we're having updates. And I also did like the point you made, Judy, about sometimes hearing from providers. So I wonder if I could bring Liz in on that, whether you would have a view on that.
I think it's a good point. We work as a system, and I think in Anthony describing the plan earlier on, he described very rightly that it's our coming together of provider organisations and the system that is going to be important in delivering the plan, and we take a collective accountability for that. So happy to take that as a proposal, but I do think it needs to be in the context of system and system collaboration and system, importantly, accountability.
Thank you, Liz, for that. I can see that Graham Clark would like to come in.
Thank you. So we've seen the operating plan that shows us the year-end position, but what we don't know is how that's put out during the year, and I think that possibly would be helpful in terms of managing of expectations of where we are when. And I guess what I'm sort of used to is also having some milestones along the way, because I think without those you don't have that framework of being able to say whether we are off that plan, and it's obviously too late to get to the end of the year. So I think this is part of my general plea, which is the calendarisation of this. I think is really important for us to have some visibility of. Now, it may have been done and we just don't have that. So it's a question really of do we have that?
Bill, would you like to respond on that? And then I'm going to bring Sheena in, Sheena Asthana.
Yes, please. There is a draft in the financial recovery plan which shows the phasing of savings and also shows the phasing of the activities that we'll be taking forward. We'll be finalising that through the System Recovery Board, and I'll be very happy to bring that back when that's finalised. We're also looking at the same things in terms of the calendarisation, as you put it, Graham, on the elective side. On UEC, we will keep track on that, but the requirement is for us to hit the target by the end of the year, certainly in terms of 4 hours, but we will be looking at that, and because we've got a significant improvement to make during the course of the year. And once we have those charts produced and they've been validated and we're confident about delivery, we will share those with the board, and very happy for those to be scrutinised.
Thank you. Sheena Asthana.
Thank you. I absolutely appreciate the need for a really tight operational plan, and I understand the direction and the focus, particularly the need to focus on the acute sector. However, we've raised this a number of times, that the risk is that we lose attention on strategic transformation, whether it's kind of focusing on preventative activities, mental health, digital, all of the various things, primary care, that we're also very, very worried about. I don't know if it's too radical to suggest it, but I sometimes wonder if we should also explicitly talk about some of the things that we're not able to invest in at the moment because of our need to get our books in order, so that the kind of trade-offs that we are having to make are explicitly surfaced, partly, I think, actually for external purposes, both our public and actually NHSE, so that our ambitions towards more strategic transformation are patent, but some of the restraints that we are working under are also acknowledged.
Thank you. A really important point, Sheena. And Bill, would you like to respond to that?
Yeah, of course. So it's quite opportune, actually. We have a meeting between the System Recovery Board and the Executive Strategy and Transformation Group next week to be certain that we can actually align the short-term recovery with the longer-term joint forward planning to make sure that those two things are synchronised with each other. So Simon and I are coordinating that, and then we'll report back to the board accordingly.
Thank you. Do colleagues have any more points on that? Because if not, thank you, Bill. We'll note that and come to the finance reports, which are in two parts. Firstly, the part relating to NHS Devon itself, and then to the wider ICS. So thank you, Bill.
Thank you, Chair. I'll take the reports as read and take them both together. There isn't a huge amount to update in terms of performance. What I would say is that at month 12, and this is the month 11 position that's being reported to the board, at month 12 there's been no material movement. The ICB and the system, the ICB recorded a small surplus, as you can see, £135,000. The system recorded the position that's been updated, that's been reported earlier, the £49.2 million deficit, and there was no material movement between the month 11 and the final accounts position. Final accounts have been prepared and are being finalised based on that outturn position, and I'm also pleased to report that we achieved the capital position that had been reported to the board during the course of the year. So in terms of what we achieved the target that we had, the revised target that we had planned to. Clearly disappointing that we didn't achieve the position that was signed off at the commencement of the fiscal year. The board has been apprised of that at length during the course of this year, and as we've reforecast the position and then set the plan for this current year. But I'm very happy to take any questions, any issues that are not clear in the month 11 position, or indeed anything that any board member would like to understand in terms of any movement between month 11, month 12, or indeed final accounts position.
Kevin Orford.
Thanks. So I'd just like to say thanks to Bill and his team and to the CFOs and the boards of the providers in the system, because I think to meet this really challenging financial target that was agreed when Bill was appointed, has done a lot in terms of restoring financial credibility across Devon. So thanks to everyone who's enabled us to achieve that. It's a great result.
Thank you for that. Any other points that anyone would like to make? No, thank you very much indeed, Bill, again for this report. So we're going to come on now to the committee chair's report for the Finance and Performance Committee. Kevin Orford.
Thank you. I'll take the report largely as read, but just something to highlight to the board, and then there are two recommendations for board approval. This report does relate to two meetings, and the big meeting in all of this was the approval of the operating plan for 23-24, which has been referenced at various times through the meeting today. And it's just to point out that on page 4 of the report, at the little tiny table at the top, if you can read it, are the headlines of the operating plan in terms of what the system in Devon has signed up to in terms of its accountability for this financial year. And if there are any minor changes to those numbers as a result of the resubmission, we'll bring that into the next board meeting. So that's just to flag up what was signed off in the operating plan meeting, and thanks to everybody who was able to attend that. People changed their diaries at the last minute to be able to come in and support us in getting that signed off. There are two items which we bring to the board for approval. The first is that we've revised the terms of reference for the Finance Committee. This takes into account the expanded role of the committee into the performance agenda, and also brings in those items from the board assurance framework which are delegated to the Finance Committee. So those new terms of reference need to be approved by the board if you can. And then the second is the approval of the delegation from the board to the Finance Committee in relation to estates, and we've attached the report which came to the Finance Committee setting out those delegations which we supported at the Finance Committee and need to be approved by the board. Now, There was a helpful intervention from a couple of non-executive directors who asked for some clarification on those estates delegations, and so I'm happy to provide that clarification in my report on page 2. And it's to be clear that, you know, we do recognise that the Finance and Performance Committee doesn't have all of the skills to assess public and other stakeholder interest in estates issues, and then particularly in land and property disposal. And so the Director of Estates has agreed that for each disposal proposal, he'll provide a stakeholder engagement summary to the Finance Committee so we can see where it's been and who is supporting it and who isn't. It doesn't change the delegation. There's no right of veto in all of this, but it means that the Finance and Performance Committee will have visibility of that. And we've also agreed that any disposal proposals which relate to community assets and primary care assets will go through the ICB Primary Care Committee, and that we'll have a communication from them on any of those before we take a decision at the Finance Committee. So thanks to the non-executive directors who asked for that clarification. It's been helpful to tighten that up. So those are the 2 items for recommendation to the board: terms of reference and estates delegations, please.
Thank you very much, Kevin. So we've got 2 areas that we seek the board's approval. Perhaps we could have a discussion first. Judy Hargadon.
Thank you. And I think we should all say a really big thank you to Kevin and the team that support him in doing this role, because our Finance Committee is becoming a bit our Finance and General Purposes Committee. I note you're now accountable for net zero targets as well. But this is the best set of terms of reference I have seen so far, and I'm about to go away and rewrite the primary care ones in the same clear language. So that's really very helpful. I'm grateful about the change to reflect the primary care properties issue, and that's partly because 5 million is quite an appropriate target for a general estates delegation policy, but quite a lot of primary care properties will be less than that. Thank you very much. I have one query which we've never dealt with. It's a generic governance issue. We've talked in here about deputies, but actually non-executive directors don't have deputies. So if we're going to find ourselves in any of our committees voting on things, we need to consider how to handle that. Hopefully we'll never get into voting, but it is an unresolved issue about non-execs and having deputies and voting.
Thank you. And I know Anne Cooper is joining us remotely. Anne, did you want to comment on that specific point?
Sorry, I had everything turned off. I think it does raise an important point, and it's you're not on your own in terms of raising it. I think something for us to take away is that you can nominate, if you cannot be at a meeting, one other NED. And definitely that's being done elsewhere. So let's, Judy, I've put a request out to meet up with you, so maybe we can try and talk that through and see if we can come up with a model that we can use for the whole of NHS Devon.
Thank you. Could I ask a question, please? There's a very helpful diagram on page 5 of the policy development and asset disposal process. And I can see through that flow chart that we get to the point where the ICB executive board is involved, but I couldn't see where this main board fits in within that flow chart. Are we suggesting it goes to the exec team, or does it come back to this board at all?
So I think it comes back to this board only if we can't agree the disposal or if it is above the delegated limits to the Finance Committee, I think is the answer to that, Chair, but I'll...
It's just it doesn't appear within the actual flow chart. We can see it goes to the exec board. It's a really helpful flow chart, but I just wasn't clear to me at what point, you know, do we need another little box at the bottom that there's that. That's just been my comment on it.
Yeah, shall I take that away and get that added in? I think that would be helpful, actually.
Thank you very much. Does anybody have any other points they would like to raise? Because if not, I'd just like to just formally check. Oh, sorry, Judy, did you? No, your microphone's on. Just want to check that we've got 2 areas for approval. So, shall we take those in turn? So, obviously, there's the issue around the change of the terms of reference. Is everyone happy with that? Thank you. So, if we could minute that, and then secondly, on the recommendations of the Finance Committee on the disposal of assets. Yes, everyone happy with that? Thank you very much, colleagues. Right, so we're now coming on to the end of our board meeting, and we have the action log. I don't know whether everyone can see that to action. We've got a few areas that we're going to be adding as a result of today's meeting, but we've also got a request to close, and this is following on from one of our previous patient voice sessions that we had where Darren Alcorn had followed up, and I had also made an offer to meet with the patient who hasn't actually taken up that offer. So I think we can now close that item. And then we have item 34, which was an item raised for the workforce strategy to be presented at the May board because the April meeting was stood down. But in fact, I think we've got a request to close that now for the workforce strategy. Yeah, so thank you very much. And then we have 5 items that are in progress. Does anyone have any queries about those or feel that they shouldn't be continuing on the action log? No? So thank you very much, if those could be updated. Now, we've had no questions from members of the public raised in advance of the meeting. So any further questions? No. So we're now coming on to any other business. Do colleagues have any other items of business they'd like to raise? No, thank you. So our next meeting of the board held in public is going to be on the 7th of July, and we're holding that at Derriford, and I think it's really important as a board that we rotate round the whole of the patch. So that will be, as I say, 7th of board at Derriford Hospital, and we'll make sure that all the details of that are circulated to colleagues and the exact venue nearer to the time. So thank you. Anne Cooper, I can see you've got your hand raised.
A point of clarification, Sarah. I thought it was the 5th of July.
Oh.
The 7th of July is a Friday.
Right, well, that's a very important point of clarification. Thank you very much, Anne. My notes say the 7th, but you're absolutely right. It should be the 5th, so thank you very much for pointing that out.
Which is the 75th.
And of course the 75th anniversary of the NHS, so it'll be wonderful to be there, and thank you very much. So no other points from colleagues. We will close the meeting, and thank you very much for joining us.